Good morning. I'd like to call this meeting to order of the Health and Human Services Finance and Policy Committee. It is Tuesday, April 14th, 2026, and we do have a quorum present. Members, we are going to take up Senate File 2689, and if Senator Johnson Stewart can come forward and your testifier. We were delayed because we are waiting for printing to print the correct version of the bill. We thought we had the correct version that was put in your packets, but there is a third engrossment, and we want to have that so that we're able to discuss the language that we should be considering.
I'm sure if you need a motion, I'm happy to move the bill when that time comes if you need it. Thanks.
Okay, thank you, Senator Abler. So I guess I'd like to just get started. If you can, Senator Johnson Stewart, if you could start by just giving an overview of your bill, and hopefully the printing will be here shortly with the new version. So Senator Johnson Stewart.
Thank you, Madam Chair and members. So I'm here today to present Senate File 2689, which has been known as the Medical Assistant Protection or MAP Act. The goal of this bipartisan bill is to protect a popular and important program that 1 in 4 Minnesotans rely on for health care coverage. That includes nearly 600,000 or 42% of medical assistant enrollees who are children. The MAP Act will improve the Attorney General Office's ability to investigate and prosecute Medicaid fraud by adding 18 new staff members to the AG's office Medicaid Fraud Control Unit, which we affectionately call MAFUCU, to account for recent increases in the state Medicaid budget and to meet the recommendations by the federal government. The bill will then increase MAFUCU staff from 32 to 50. That appropriation has already been amended to last year's bill and approved by state and local government, which is where that appropriation will find its place if funded. I do have a testifier today, Mr. Nick Wonka, who is the head of the Medicaid fraud investigation unit, and so after I talk about the amendments, I will hand it over to him. This bill has been amended twice. In addition to the amendment that went through state and local government, we heard the bill, or the bill was heard yesterday in judiciary. The first amendment, the A6, which you will see in the third engrossment, adds to the subpoena powers that are allowed by or granted to the Medicaid Fraud Control Unit. Those are outlined in Section 1. An important piece of the amendment is an addition for the Medicaid Fraud Control Unit to demonstrate intent by those who are charged with Medicaid fraud. Intent is an important legal term, and if you have questions, my testifier can talk about why that was an important addition to this bill. It also provides allowances for it grants allowances to the MAFUCU for them to have similar subpoena powers to other branches of the state and federal government, and you, of course, can ask him about that. Yesterday, the bill was also further amended to define what those subpoena powers are, and you'll see those in the third engrossment. I think with that, and given interest in time, another thing that happened is the Medicaid Fraud Control Unit met with the Sentencing Guideline Board just late last week, and so another tier of crime definition was added, and you'll see that in Section 3, I believe. So, Madam Chair, I would like to hand it over to my testifier unless you have further questions.
Thank you, Senator. We can go to your testifier. Mr. Wonka, if you could please state your name for the record and begin your testimony.
Yes, good morning. I'm Nick Wonka, the Director of Minnesota's Medicaid Fraud Unit. And I'm here to testify today in support of this bill, which will help ensure that we in Minnesota continue to be able to investigate and prosecute fraudsters who steal taxpayer dollars that should be dedicated to providing critical health care services to Minnesota's most vulnerable people. Now, just a brief overview of who we are. Minnesota's Medicaid fraud unit has existed for over 40 years. We're one of 53 in the country. Every state has one, as do DC, Puerto Rico, and the U.S. Virgin Islands. We investigate and prosecute our own criminal cases. Right now, our budget's for 32 people, and our staff has 7 attorneys, 17 investigators, 2 analysts, 2 paralegals, and 4 support staff, all of whom, as I'll cover shortly, spend 100% of their time working in a single area, investigating and prosecuting Medicaid provider fraud and the abuse, neglect, and financial exploitation of vulnerable adults. Now, each med fraud unit is funded by a federal grant from the Department of Health and Human Services Office of Inspector General. That grant covers 75% of our funding. All costs, staff salaries, tech, rent, you name it, it's covered. But it comes with those conditions on what we can and can't do. It requires us to spend 100% of our time on those approved activities, provider fraud and the abuse and neglect of vulnerable adults. We have original jurisdiction for provider fraud under state law, and we can investigate and prosecute those crimes and crimes that arise out of it, which are most often other financial crimes like money laundering and identity theft. And we also do patient abuse and neglect cases. That often means crimes against vulnerable adults or elderly residents in nursing homes, assisted living facilities, and other similar settings. We don't have original jurisdiction for that, but we can prosecute it on referrals from county attorneys, which in the last 4 months has included financial exploitation charges against individuals in Chippewa County and abuse and neglect charges against individuals and corporate actors operating an assisted living facility in Anoka County. And finally, we can assist federal law enforcement in their investigations. That can include interviews, data analysis, assisting with executing search warrants, and other matters. Our investigators spent most of their time last spring, summer, and early fall on tasks like this when they worked with agents from the U.S. Department of Health and Human Services and the FBI performing data analysis and field work. But with those federal requirements and funding come certain prohibitions too. We're the investigators and prosecutors, but we are not the administrators of the program. For example, federal regulations require us to be entirely separate from the agency that administers the program, which here is DHS. So we can prosecute it, but we can't turn off payments on the front end or bar a certain provider from enrolling with Medicaid or continuing to receive payments. We can't do that type of compliance work. We also can't investigate or prosecute fraud in obtaining benefits, also known as welfare fraud, or fraud in other public programs like child daycare. Now, how do we get our cases? They come to us in referrals. Most come to us from DHS or managed care organizations. We also get them from various law enforcement agencies and other state agencies and tips from the public. And those have dramatically increased for us in the past years too, just as our Medicaid budget has grown. In 2019, when we went up to 32 people, we had 144 unique referrals that year. We've been well over 200 referrals the last few years, which is over a 40% increase with no additional people to take on that work. And the cases we're getting are only more complex. Gone are the days where most of our referrals are on individual workers. Now we have primarily referrals on entire agencies, which, as you can imagine, take more resources to investigate than a single person. And to put a finer point on it, since October 1st of this year, which is the beginning of the federal fiscal year, we've already received over 300 separate referrals, which already exceeds what we've received every federal fiscal year in the past. And that's just through early April. We have another 6 months in the reporting period to go. So the MAP Act covers both a budget and policy request. And our budget, as I mentioned, is approved by the U.S. Department of Health and Human Services Office of Inspector General, which again covers 75% of the costs like it does for every MFUCU. They decide our budget and our unit size based on the size of our state Medicaid budget. So California has a bigger Medicaid budget. They have a bigger Medicaid fraud unit than us. South Dakota has a smaller budget. They have a smaller med fraud unit than us. And when our staff size was set at 32 back in 2019, our state Medicaid budget was $13 billion, and we were getting 150 referrals a year. Our state Medicaid budget is now well over $20 billion, with many more enrolled providers than before, and with our referrals likely to more than double what we received 7 years ago. Yet we still only have 32 people to investigate and prosecute this increasing number. That's not sustainable if we want state prosecutors to be able to hold fraudsters who defraud this state accountable. And just looking at us compared to other states too, as you see in your handout, you'll see how much smaller we are than some other states with similar Medicaid budgets. Many of these states even have smaller Medicaid budgets than us, yet larger Mafuku staff sizes. But that size hasn't stopped us from getting results. The investigators and prosecutors in this division have done great work, as our results can show. We regularly exceed other units with many more people in fraud convictions. We had the most from 2020 to 2022 during our audit period, as compared with similarly sized states with staff between 22 and 38. And that has continued since then, as the past few years we've outpaced others. Last year, we ranked 6th in investigations per Medicaid expenditure, 5th in fraud charges, and 8th in fraud convictions in the entire country. And we don't have a top 10 staff size. We're about 21st. And just to discuss the long term, we're on average 5th in fraud convictions in the entire country over the last 6 years. That's a long-running track record of success for our unit when compared to other states. So we are asking you to give us the 25% necessary to expand to 50 people, which will give us the resources we need to hold fraudsters accountable at a state level. You pay 25% and the federal government pays 75%. So out of the 18 people, you're paying for about 4.5. That's a good deal for the state. There's also policy changes in this statute. That includes amending the medical assistance fraud statute to cover current gaps within it. These new statutes address issues our prosecutors face every day in district courts and help us ensure that fraudsters can be held accountable. Right now, our statutes, as some judges read them, just cover intentionally submitting false claims for reimbursement. Some of these judges construe that very narrowly when we know that fraud occurs in other manners too. This policy change addresses these gaps. That's done by, as you can see, covering a variety of different ways that fraudsters try to steal from the Medicaid program or escape culpability. For example, it covers intentionally providing false information on enrollment documents to conceal the identities of people who are not allowed to be providers, intentionally falsifying medical assistance records, intentionally destroying records in response to a lawful request. And while these crimes cover different conduct, they still ensure provider rights are protected, and we're not catching accidental mistakes. That's done by requiring that we as a state prove intent to defraud, or an equally high intent for these violations. Now, intent to defraud is a specific legal term. Covers the mens rea or mental state that the state must prove a defendant has when the crime is committed. It's the highest level of mental state that exists in criminal law, and we've proven that to juries before, and we will continue to do it if you provide us with this amendment. The statute also includes a new provision targeting the most egregious offenses, over $1 million, as a separate penalty provision. This ensures we have appropriate accountability for those who get obscenely rich, stealing money that's supposed to be going to the most vulnerable people in Minnesota. And the new provisions regarding restitution and continuing offenses will help us ensure that those offenders are ordered to pay back all of the money they stole. The remaining provisions ensure that we still have original jurisdiction for these offenses and grant us some subpoena power. For the subpoena power, we're asking for similar subpoena power that county attorneys have when they conduct criminal investigations. This revision would allow us to subpoena financial records and provider fraud investigations conducted under Minnesota Statute 256B12. County attorneys already have this authority when they conduct welfare fraud investigations, also known as Medicaid recipient fraud. State agencies like DHS have this authority when they conduct their administrative investigations. And the federal government has this authority when it conducts its investigations into healthcare fraud. Granting us these revisions aligns us with these other investigative entities and is consistent with the judgment that all investigating authorities should have equal power to subpoena records when they're investigating providers for defrauding public programs. That's our request, and so we'd ask that you give us those amendments and that budget allocation so that we as a state can continue to hold fraudsters accountable. Thank you.
Thank you very much for your testimony. Members, do you have questions about the bill? Senator Utke.
Thank you, Madam Chair. And a couple questions to our last testifier. You talk about the credible allegations. What are those? Are they tips that are submitted to you? Are they, is it data that's passed on from the agency that's credible? Could you elaborate a little bit further?
Mr. Wonka.
So are you talking about the referrals that we get from other people?
That is correct.
Senator Utke.
So they come in all different forms. Sometimes they come in a fully worked up administrative referral that comes over from DHS after they have made a determination there's a credible allegation of fraud and suspended payments to the providers. Federal regulations require them to send us a referral. if they have a credible allegation of fraud and they suspend those payments. The same thing for MCOs. We get referrals all the time from MCOs on the same grounds, right? They've conducted an administrative investigation, they've suspended payments, they send it to us for a potential criminal investigation. We also do get tips from other law enforcement agencies. Sometimes a tip will come into a local law enforcement agency. They'll say it's Medicaid fraud. It's a smaller jurisdiction. They'll send it to us to investigate and prosecute. Sometimes we work with the BCA in the state fraud unit. If they have a Medicaid tip, we'll work together on it because that's all we do, whereas their state fraud unit does all types of program fraud, and we can add some value there. Sometimes they do come in as tips from the public. A lot of times those come to the AG's consumer hotline. They get forwarded to us, and we take a look at them. I would say those are probably the most common way that we get them. We do get them from other state agencies too. Sometimes the Department of Health will be conducting a survey of an assisted living facility, see potential billing fraud, and send that over to us as well. So,
Senator Radke.
Thank you, Madam Chair. Another question for you. And typically, the Attorney General's office is not going to be sitting in front of our committees. So my question, you can let me know if it's been heard before, but I guess as I'm sitting listening to this now, we're talking about fraud, and fraud has been a big issue for the last number of years. Have you or has the Attorney General's office been asking for this same type of expansion as far as additional staff and monies over the last couple of years? And I would guess you probably end up in judiciary or something with that request. Has that been ongoing, or now it appears everybody's all on board with fraud because it's all over the place? Were we proactive or are we just reactive?
Mr. Wonka, or Senator Johnson-Stewart? Mr. Wonka.
So we were here last year. We didn't come before you, but we were in the House, and it passed the House, but didn't get anywhere in the Senate. The reason that we were there last year is because we got an analysis from the Department of Health and Human Services Inspector General about our unit size. They had reviewed our state Medicaid budget and said, you guys are too small. Your budget is growing very quickly, and you don't have enough people to keep up with it, and we are recommending that you expand. So that's why we came in last year for this budget increase. It didn't go through. Now we're back again, hoping that we can get some progress this time.
Senator Radke.
Thank you, Madam Chair. Just one last question then. As far as an internal operation at the Attorney General's office, I think you're saying there's 32 attorneys assigned to this type of business, thereabouts. Doesn't the whole agency have about 200 plus attorneys? Is there the possibility of, when you're running tight in one area, don't you shift personnel around to cover the bases?
Mr. Wonka.
So it's not 32 attorneys, it's 32 people. Most of our staff are investigators. They're the boots on the ground who are going out and knocking on doors and talking to people, requesting records, doing a data analysis, things like that. The reason that we're here asking for this is because we can't just take people over and have them temporarily fill these spots. People in the Medicaid fraud unit have to spend 100% of their time on Medicaid fraud if we want to have a federal match for this and not have the state paying 100% of the costs. We want the federal government to give us that 75% match. So we also need to have an assurance that we can tell the federal government that this money that we're allocating for the state match is exclusively dedicated to Medicaid fraud. It's not something that we're just temporarily borrowing from another division. It's going to be here, and it's going to be here long term, and that's why we are asking for this specific allocation, which is going to exclusively go to Medicaid fraud and is going to exclusively fund people who spend all of their time on provider fraud and don't do anything else in the Attorney General's office.
Thank you, Madam Chair.
Okay.
That's it.
Senator Abler. And then
Well, thanks and welcome, Mr. Wonka. I support your effort. I'm a co-author, so that's where I come from on this. And I appreciate what you're doing. I just have some questions about, so I was talking to Mr. James Clark, and he said there were 540 cases referred to you, and there were 16 lawyers, and actually he was hoping for 16. There's only 7, it sounds like. So can you tell me how many cases you have now? And could you just kind of go through the disposition timeline, like how many are open, how many get resolved, what's the average time from when they go there? And is that easy to start question? I'll have a follow-up, but thank you.
Sure.
Mr. Wonka?
So I would believe, I mean, if he says they've sent over 540 referrals, I would not have any reason to doubt that. The length of time for disposition is, of course, going to depend on the facts of a case. Like, we get a referral, and then we have to make a decision on whether to accept or decline that referral within, under the federal regulations, a reasonable period of time. When we only have when we only have 30 to process, that's going to be quicker than when we have 300 to process. But we do try to get those in a matter of weeks, if not quicker, but as we get them. If we decline a referral, well, whether we accept or decline a referral, as soon as we make that decision, we notify DHS. If we decline that referral, we don't take any further action on it, right? If we accept that referral, we will open it for an investigation, assign it to an investigator or two and an attorney, pair them up, and then they'll go out and investigate the provider. If it's an individual provider, that case may be investigated and charged within a year, and then how long it takes to go through the court system is going to depend on, the court process. If it's an agency, it may take longer, particularly if it's a person who owns a network of different agencies, right? Like, we have cases right now where you have one person who may own an EIDBI provider agency, an HSS agency, and a waivered services agency. That's complicated investigation. So that investigation may take a few years. So it's a little bit fact dependent, but that's a very, very high level overview that I can give you as to, our process.
Thank you.
Senator Abler?
So is it fair to ask what percent of the cases do you accept that come your way? Like half of them have enough merit that you want to investigate, or just a ballpark? I'm not trying to get rid of your trade secrets.
Yeah.
Mr. Wonka?
I don't know that I have a percentage. I can tell you we have over 200 open cases right now.
All right. Well, and so,
Senator Abler?
And so part of my concern is about the due process for individuals, and I'm working on some of that, and I know you're all about that as well, so I'm not saying you're not doing that. But and so sometimes these assertions where they're an indicium of suspicion, which is a ill-defined term, which I'm not particularly fond of, but the feds made it up, so another goofy idea they have. Anyway, and so when you decline a case, sounds like they could be tied up forever if you have enough substance, and so they might as well just close up shop and just wait for the criminal charge, probably, but if they're really doing the wrong thing, which we do not want. But so do you know what happens to the cases you decline? They go back to the department? Do they go like, well, that was that? They turn the payments back on, or do you know what happens?
Mr. Wonka?
I think that that's really a question more for the department. I mean, I know that at a high level, the regulations, it can be subject to different interpretations, quite frankly. There is one interpretation that if we decline the case, that the department no longer has grounds to continue a payment suspension. There are other interpretations that they still have grounds to continue a payment suspension if there's another investigation going on. But of course, if we decline it, then and they continue a payment suspension, then there may be different remedies for the provider, including like contested case hearings and things like that. Whereas if we have an investigation underway, I mean, if you look at the federal regulations on payment suspensions, there are times where even when there's an active investigation going on, a payment suspension can be lifted, but those are with the discretion of the Department of Human Services. We do not have the authority to tell them, turn on payments, turn off payments, because they administer the program, and we're just, we're there to investigate and prosecute crimes.
Yeah, that's helpful. And
Senator Abler?
And so just a couple more questions to the bill. And so it's improved a lot. I appreciate that. I'm happy about the intent. On line 3.2 and 3.8, it has the word reason to know, at which point they could go away for a long ride. Always trying to protect the innocent, as I know you are, and crack down on the bad guys. I like the intent part. But is there enough protection and are the judges and everybody reasonable enough to not do something bad? So they had a reason to know that they were suspended. So I'm a minority owner of a business, and I'm busy. They just run the thing, and I could have known that they were suspended, but I'm busy and I had no intent at all. Is that a snag that is going to snag a tuna instead of a dolphin instead of a tuna in the net?
Mr. Wonka?
So the reason that we have this, and so we thought about that, and both suspensions and federal exclusions are publicly available, and actually owners and managers are required to check that list. That's in a separate statute when they open a business. So they should be checking that list as is. And the reason that we have knowing or reason to know in here is because what we don't want is to have an owner or manager who says, yeah, I know I was supposed to do that, but I just intentionally buried my head in the sand and didn't check the list. And so we want to avoid that problem. And that's why we have knowing or reason to know. If you're legally required to check an exclusion list when you open your business and you choose to not do that, and you let somebody else run your agency who you did not disclose to DHS,
Okay.
that's
Last question.
Senator Abler.
I appreciate you allowing me to ask these questions. On line 4.7, it talks about failure to keep records. I've got 47 years in practice, and some of my records aren't really as good as I would like. So might I go to prison if I didn't keep good records? And is that just like, if they're just like glaringly horrible records, if they fail to keep, and so it's references 245A and 245B, and I can't find the section in those that says about records, but is this, I mean, obviously if you falsify, that's a thing, but just what if your records kind of suck? Is that, is there a thing here for just well-intended but slacker owners?
Mr. Wonka.
So I appreciate that. I think that everybody could say nobody's records are perfect. But number one, we left this as a non-felony offense for that reason. And we also included something here that requires knowingly and intentionally failing to maintain the record. So it's not an accidental mistake. It's not I missed, I have 98% of the timesheets, but I'm missing these 2%. This is meant to address those situations where we execute a search warrant in an agency and they have no records at all to support any services billed, which is something that we see, right? You go out and you're like, wait a minute, this agency's operating out of a mailbox. They have no records at all, yet they've billed for millions of dollars in services. You go to their alternative locations, still no records. People tell you services weren't rendered, but you also have a lack of records here to support it. And so that's really what we're getting at here, and that's why we included knowingly and intentionally.
Madam Chair, thanks.
Senator Abler.
I appreciate those questions. I'm glad I'm a co-author, so thank you.
Thank you. Senator Coran.
Thank you, Madam Chair, and to the AG's office as well. So when you talk about the referrals, you described that most of them are real referrals from agencies who have done at least a preliminary investigation. But the majority of them, you said, come in from tipsters or individuals. You said most of them come in from individuals.
That's my mistake. Then most of them come from DHS or managed care organizations. I apologize for any confusion that I may have caused in my comments.
Okay, yeah, because I was going to ask, Madam Chair, and so I was going to ask, if they come in and it's not a verified referral, do you refer them back to agencies? Okay.
Mr. Wonka.
Yes, there's times where we may get a tip that says, I think my neighbor's not providing PCA services, and there's really a bare minimum of information. We don't even have the identity of, the person, or like, what are we talking about here? Yeah. We're going to refer that to DHS at that point and say, look, conduct your administrative investigation. If you find something, send it back to us. We'll criminally investigate it at that point.
Senator Coran.
Madam Chair, thank you. And the comment is that I'm glad the scope was refined a little bit. Right, many are worried about fishing expeditions. I'm not sure you have a lot of time to do that, but I think the AG has some conflicts in all the fraud that we've seen, right? And that's legit. So I don't think that, I like it because I don't think it's necessary. That expansion, and much like the bill I support as well, is an independent inspector general's office to do the work of statewide. We're doing all these things, so we're chasing the tails because our agencies are failing at a higher level. They're not doing their job to guarantee that every single person is validated, right? From program management to documentation to, did you just show up and check the post office box and the vacant, right? Mm-hmm. We're talking about sophisticated crime in one element and the rudimentary fundamental things are just not being done. You'll never be able to, we cannot and should not staff you to do their job, nor in the independent inspector shouldn't do that. We got to keep focused and make sure they do their jobs. And so far, nobody's had an interest to do that. That's not your fault. That's not your problem. But I like the changes on it. But I think we have a compounding problem. If I'm recall, we don't allow, you talked about thorough background checks of who a Medicaid provider is and who recipient is and who can bill, but I believe the program managers who manage for the state, we've prohibited them. They don't even pass their own basic background standards because we're the state of Minnesota and these shady businesses have popped up everywhere. They've identified them. Do you receive referrals from, I'm kind of curious what that pathway is when they find an inappropriate or somebody would never pass their basics, yet they're continually required and pressured to approve them and make the payments for which then you're on the backside trying to go out and investigate and catch them. And so we've got a disconnect in a couple of those areas. We either have to allow those, like all programs, they're much more thorough than any of our agencies. And if it's Blue Cross, Blue Shield, whoever is managing all of those for us, they're prohibited by law. And so I think that's when, for us, we should allow them to vet those people for which our agencies refuse to do and kind of stop the agencies from doing it. We're creating our own problems. So thank you. I'm glad the change has been made. That's all I have, Madam Chair. Thank you.
Thank you. Any other member questions or comments? I think you've touched on a lot of the discussed the changes from last year. I do appreciate that there has been more focus on including words like the intent and strengthening that, because I feel like last session it was a concern that maybe we would be drawing in cases that shouldn't be. So I appreciate that work has gone on. I don't know if there's any more you can say about just the work you do with the DHS Inspector General's office in terms of, are there guidelines that come from the federal government in terms of how that interaction is supposed to work, or do you just have state-driven policies on that? Mr. Wonka?
Yeah, so the federal guidelines, the first thing they say is we have to be entirely separate from the Medicaid agency, right? So we can't use them to get records for us. We can't say to them, hey, you have subpoena authority to get these records, go out and subpoena them and give them to us. We have to be entirely distinct, separate agencies. And they do their investigation, they finish it, and they send it to us. We can't do a joint investigation with them. But they also are the ones who, decide at the initial step whether there's a credible allegation of fraud and whether their payments are going to be suspended. And then they can also decide, hey, we got some new information about this, we're going to turn payments back on. They're the ones who consider that, whereas by the time it gets to us, those decisions are made. And regardless of our action, we may take a case or we may not take a case, but ultimately they have to decide, is this something that we should allow this provider to continue receiving payments for, continue providing services during the interim period of time?
Thank you. I'm not seeing any other questions or comments from the committee. This bill does need to go from here to the Human Services Committee. I appreciate your bringing the bill forward to us, and I appreciate your time, Mr. Wonka, in explaining the bill so thoroughly, so thank you. Members, without further questions on Senator Senator Kupek. Senator Kupek's motion that Senate File 2689 be recommended to pass and be referred to the Committee on Human Services. All those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and Senate File 2689 is passed and referred to the Committee on Human Services. Thank you very much.
Thank you, Madam Chair and members. And will everybody please tell Senator Abler that I thanked him as my co-author?
Thank you.
It's on record.
All right.
Thank you.
We'll do that. Thank you. Members, now we will move to not a bill, but a discussion. We have a couple different topics that we are going to proceed with. First, we are going to hear from Jan Malcolm, and We wanted to give members more information and context about what her work has been and what she's been doing over the past few weeks after being appointed as a governor's advisor on the topic of hospitals and healthcare systems in general. And so welcome to the committee, Ms. Malcolm, and please go ahead and begin.
Thank you very much, Madam Chair and members. Good morning. I am Jan Malcolm, and as Chair Wickland said, I'm currently serving as a senior advisor to the governor on hospitals and health systems. My role is to work with the health subcabinet, a group with which I think you're familiar. And that health subcabinet has a lot of very talented agency staff and leaders working on all kinds of healthcare finance and healthcare policy issues. But they have a lot on their plate, as I'm sure you can appreciate, as do you. So I was asked to come in to be an advisor to the subcabinet and to the governor, just to give them sort of some more bandwidth on this emerging set of issues, certainly with Hennepin Healthcare in specific, but beyond that, as the chair said, looking at the larger health ecosystem as we sometimes refer to it. So I am there as really an extender of the expertise that exists in our agencies and our good staff at the subcabinet. Since I was appointed to this role in March, I've had literally dozens of conversations with health system leaders, with legislators, with stakeholders, and with folks within the administration. And the goal there is to really understand their perspective on what's happening at Hennepin Healthcare in specific and what's happening in the broader system and what sorts of issues do we all need to be thinking about now, immediately, as well as in the future with future pressures that we understand are building. How do we see that landscape changing in coming years, especially due to the changes from H.R. 1, which I know the committee is learning about, as are we, and not all of that is clear. There's still important guidance yet to come on how H.R. 1 will be implemented, but I think everyone in healthcare is very aware of the seismic impact that will have. This committee has heard some very strong testimony, and there's really been some very good, I think, reporting in our community about commentaries on the editorial pages of our newspapers about what's going on at Hennepin and broader. I know you've heard that. I'll just recap a couple of those key points. I think one of the good things to come out of all of the time and effort you and others are spending on this is a much greater appreciation for the absolutely critical role that Hennepin Healthcare and its flagship hospital, HCMC, play. It is a critical statewide asset and a regional asset at that. It is lauded as one of the best trauma centers in the entire nation and is really held up as a national leader in outcomes for complex populations. So it's not just about any individual service. It's Hennepin's approach to care for some of our most complex populations. Others literally look to it as a model. And as has been coined, it's one of the only hospitals in the healthcare system that always says yes to patients and community needs. And that has come under some discussion as to whether that's a sound business strategy, but it is a fact of their operating philosophy that all have come to rely on to some degree. These long-standing issues about HCMC's business model, their unique role in the community, as I say, have been there for a while. The highly disproportionate share of uninsured patients that seek their care there, as well as a disproportionate share of patients who are insured, but who are insured by Medicare and especially by Medicaid, which pays hospitals significantly less than their actual cost to deliver care. This financial burden has historically been supported by pretty complicated, numerous state mechanisms. And I will note, some of those very mechanisms are going to be diminished or removed altogether under H.R. 1 if it goes forward as passed. But beyond those complicated state financing mechanisms, the significant burden has been borne by Hennepin County taxpayers alone, despite the large share of patients coming from every other Minnesota county outside of Hennepin and from other states in our region as well. But now, as you've heard, these underlying and longstanding issues have been significantly exacerbated by some unusual and unforeseen events, like the closure of UCare, the national Change Healthcare claims payment system debacle, and the impact on patient care from the Metro surge. And these kind of unique challenges hopefully are one-time, non-recurring events. But the ongoing challenges that, again, are contained in federal policy change will be even more significant. These accelerating problems are not unique to Hennepin, but they are concentrated there to a great extent. Literally every hospital or health system I've spoken with reports the same unsustainable trends. Almost all of them have been experiencing continuing operating revenue losses, meaning what they're actually getting from an operating the business perspective quarter over quarter and year over year. For some of our systems, many, that operating income shortage has been temporarily balanced by investment income on their reserves, something which notably HCMC as a public institution is not allowed to have. Almost all hospitals and health systems also report a growing share of their patient populations and revenues coming from underfunded public programs and from rising uncompensated care costs, as we've seen changes in the commercial market over the last years. And this is even before, again, the impact of HR 1 is fully felt. But it's enough for all of the health systems to be sincerely questioning some of their long-held premises about their business models. In addition to our urban safety net, these efforts are particularly acute for our rural hospitals, with cascading effects on the economies of outstate communities. I'd commend to you, if you haven't seen it, there was a really good article in Sunday's Star Tribune really taking a broader look at the economic impact of what's going on in our healthcare systems on rural communities. I've really been struck by the strong consistency in what I've been hearing so far from our hospital and health system leaders. They do clearly appreciate the critical importance of HCMC to the whole ecosystem. We all learned a great deal during the pandemic about how truly interdependent the pieces of our healthcare system are on each other. They do clearly understand that HCMC plays a critical role as part of the safety net. If we were to force other hospitals to assume the functions and patient populations of Hennepin, and I'll just point out that today we do not have the regulatory tools to do that, even if we wanted to. But if we were to do that, all it would really do is just hasten the deterioration of the other hospitals' already concerning financial conditions. And again, very importantly, this is not just about finances, it's also about outcomes. Everyone acknowledges that Hennepin Healthcare is very good at what it does in caring for some of these very complex populations. With a clarity that I've really not heard before in my really many decades working in this field, our health system leaders are saying that the business model of healthcare, is fundamentally broken. Let me share with you just a few of the examples of things that they have said. One leader observes that we've never seen the kind of contradiction or polarity that we're seeing today. We are on the verge, literally, of such incredible clinical and technological progress that could produce outcomes at a patient and population level that we would be enormously proud to see. But at the same time, we have no idea how to pay for it in the minds of our healthcare leaders who are seeing the current system really crumbling. Another leader came up with kind of a great analogy, I thought, refers to the U.S. healthcare financing as a Jenga tower that has been built over time, haphazardly adding layers on top of what turns out to have been a very shaky, if not non-existent foundation. And now, this leader observes, people are starting to randomly pick parts out of the Jenga tower without really appreciating what are the load-bearing pieces of that structure. Another leader has said, we're all heading toward the same fiscal cliff, albeit at different speeds. It's just that some of us already have our toes over the cliff. Also new in these conversations, besides that kind of fundamental acknowledgement that the business model is really not suited, not fit for the purposes that we want out of our healthcare system. In addition to that candor, these leaders are increasingly acknowledged that healthcare already costs too much, and that this cannot just be about continuing to pour more money into the Jenga tower. They acknowledge that there is a lot of money in the system, but it's not very well distributed from the perspective of the outcomes that we're getting. And here's what I find really heartening and really, I think characteristic of the culture of our health and public health systems. They are really expressing a sincere desire to lean in on offering sustainable solutions to these more fundamental structural questions that aren't just about one piece of the puzzle or another. It's about the interconnections. They strongly urge that we must find ways to improve the payment rates in our publicly funded systems as more and more patients are going there. But it's not just about raising the revenue, it's about reforming the system and making sure that the resources are going to where they do the most good for patients and communities. And they're also talking in ways I have not heard for a very long time about how do we make better use of our collective resources? How do we think more about exploring collaboration, maybe more shared services, maybe some ways of decreasing the administrative complexity in our systems? And I think that's really excellent. We did learn a lot together collectively during the COVID pandemic. I can't tell you how proud I am of our healthcare system and public health system in Minnesota, the way that these systems collaborated together and figured out ways to move patients around the system to meet their acuity needs. They were working at, as a whole system, thinking about how they could support each other, not just in separate silos. And some of that sentiment is what I'm hearing from them now. And I'll just be the first to acknowledge it's easier said than done to figure out how could we collaborate better? How could we reduce the competitive heat, as one said, in places where it does not serve the public good? There's a lot of places where competition is great for innovation and patient choice, but they're questioning, the ways in which and the places in which we could maybe do better if we thought more collectively about capacity and needs. Again, early conversations, very conceptual, but a tone and a sincerity and a specificity of some of the things that they are wanting to talk about and look at that I truly find encouraging. With that, Madam Chair, I'd be happy to take any questions either about these conversations or my role, whatever is helpful to the committee.
Thank you very much. Members, do you have a question? Senator Curran, I'm sorry, I was looking that way, but Senator Curran.
Thank you, Madam Chair, and Ms. Malcolm. We talked about Hennepin healthcare. I kind of wish we were all together. We're running out of time for Hennepin, but so in Hennepin, you've been on the advisory now. You've talked to peers that I assume your health cabinet. I sounded like that was mostly state agency personnel, but you've talked to other stakeholders. I assume that's your role. What advice have you given the governor for how should Hennepin County healthcare be governed and managed? I'm pretty sure we all agree it's not going to be the Hennepin County Board of Commissioners. And so what preliminary guidance has been provided to the governor, because we are all going to be asked, which is a vital resource. I'm 100% on board. But in order to convince Minnesotans, one, it matters to everybody, but also even those that really care in the metro and everywhere else as well, is what's going to be that short-term, mid-term, and long-term solution. But one of it's going to be with who's going to govern it. And we're going to have those answers, or at least a roadmap defined to be able to do so. It appears you're in that role. What guidance have you provided so far?
Ms. Malcolm.
Madam Chair, Senator Cran, thank you, and thank you for your efforts to educate on Hennepin's role as well. I think that the county board was very wise 20-so years ago when they decided to set up a separate board for the hospital. I actually was on that board initially when it was first started, a point in time when I was running the Courage Center. And I think that model worked quite well. I think in recent years, the board has become perhaps more politicized. And I think one of the suggestions, and I'm glad to see that the county itself has said it intends to reestablish a community board. My hope would be that it would be a professional board made up of people with the requisite skill sets to manage a complex healthcare organization. And as I'm sure members know, typically the role of a board, the board has the responsibility to know what skill sets are needed and to find and vet candidates for the board. I think that's an appropriate governance role rather than members of the board being politically appointed. That's my personal opinion, not speaking for the administration in that regard. But I think holding the county to its goal of replacing the board, but giving some suggestions to the county about the proper model for a separate governance structure would be important. I think what exactly the governance looks like might depend on some conversations that I know that HCMC is having now and is eager to have, and that is kind of back to this notion of how are we going to do things differently? Are we going to collaborate more on some services with potentially other systems? So I think that could have some role on the specifics of the governance structure, but the key part being really a professional board with the right skill sets.
Madam Chair.
Senator Cran.
Thank you. I think we agree that I was pleasant. You acknowledge the political ideologies kind of governed that entity, and Hennepin County did the right thing by removing it. But what I haven't seen in this administration nor any others today, how to reestablish without that political ideology being the underlying factor. And we have to have true professionals have experience in it, along with the medical profession. And what I was worried about, and I don't mean to, you said, well, we've got to have another community board. No, we don't. We need a group of highly skilled people that understand the function and role of managing a complex system. And then we have to give them more tools on how to, the continuum of care, the proper care through the right channel, and all of those things. And so we're going to need somebody that's really competent, really aggressive at doing that, and we're going to have to support them. But we're going to also have to write a big check at some point in the very near future to keep them afloat. And at the same time, they're going to cut millions of vital services, which we're already going through. So I appreciate it. Thank you.
Senator Abler.
Well, thanks. Do we still call you Commissioner? I think that's your highest, maybe you had a better job, just human being. But hey, welcome, Citizen Malcolm. Really happy to spend some time with you chatting, and appreciate your expertise you're bringing to this. And I think your trusted experience was a good choice. And so I have some thoughts to express, but first I have a question. Since you've been talking to him, and you remarked that he had some suggestions. What is the governor's position on funding? I noticed that the bill, at least as I read the budget bills, I don't see a lot in there about HCMC specifically or hospitals in general. Can you comment about that, please?
Ms. Malcolm.
Madam Chair, Senator Abler, I think the language in the governor's budget, excuse me, I'm out of practice. I forgot to bring water to the stand. Has a role for the health subcabinet to continue working on these larger complex issues we've been talking about. he has said very clearly that Hennepin is an essential asset that needs to be protected. I think there's a lot of conversation going on within the committees of jurisdiction about kind of what is the right approach to both the immediate needs, which, as Senator Cran and others have observed, are immediate. And it seems to us as we talk about this, and I'm again not speaking for the governor at this point, but that there's just recognition that this is a puzzle with multiple parts, some direct funding to HCMC for probably a set period of time, and then perhaps to set up a very targeted larger pool to deal with some of the kind of common trends that are facing especially rural hospitals. But it would have to be extremely targeted. And third is this robust effort that we've sort of been alluding to of really engaging in more of a redesign effort, both on how our programs are built, but also how care is paid for and delivered. That really, it's not totally separable from this Hennepin situation, because any funding issues are going to run into the same, any funding solutions are going to run into the same structural challenges if we don't also deal with just the underlying business model problems that our professionals are calling out.
Senator Abler.
Thanks, Madam Chair. Actually, I appreciate what you're saying, and I know you're not him, but I think that it's time for him to get in front of this a little bit. I think there's some challenges, the whole Fairview thing, and it's just, I try to be as kind to him as I can, but it's time to lead would be my comment. And so I have a few suggestions to him that he might enjoy. I'm waiting for my jackets to come down, which are out of date now for the ideas. I've improved my idea, Madam Chair, so I'm going to offer a couple thoughts. One is I suggest that in the HCMC and all the hospital discussion, we separate the impact of the OBBBA, which is a new acronym, HR1, from the impacts of what we have today. There's plenty of troubles that we know we have. We do not know the impacts coming, and I don't think it's possible to get our arms around that until they actually begin to land, knowing that they're going to in some way, which at least helps divide the labor up. I suggest that we repurpose the surcharge and dip into the till as a statewide value to an extent that makes sense to help a bunch of the hospitals. Right now, I suggest they all keep paying in, so that way there's no discrimination or anything. Thank you, Mayo, for chipping in on that too, helping the good of the order. But I think there's a way to work with Senator Wickland's uncompensated care pool that she's brought forward, or some kind of fund that the higher you're on a sliding scale, the more Medicaid, Medicare people you have, you get more of that back. Similar to that idea. And so the lower you are, you pretty much get nothing. You draw a line at 30% or something and put out $200 million a year or something like that. I think the fund is $230 million, but we are taxing hospitals that we need to subsidize, which seems kind of counterproductive. I do suggest we also, if you rebase to the maximum ability that we have, you won't need as much money out of that pool. And the feds are rolling in dough, Madam Commissioner. They're only $39 trillion in debt, and so why not ding them again? Nobody seems to think that's a lot of money. I was worried, Madam Chair, that when we had a $10 trillion deficit, so that's me. And in talking to HCMC, they could use some flexibility in particular, and I don't know if other hospitals need it as well, but in your tenure, you been part of some of the rules that run hospitals, and some of those no longer make sense. And so my idea was that if the administration of the hospital and the nurses would unanimously agree that there are some things they could suspend and just not do. I know JACO has some pretty high standards anyway. I'm trusting the safety of that because of their commitment on both parts to that. And then finally, the board has to change. It's a county thing, but I wound up running a restaurant, and I got good at it after a while, but we had a partner who was running it, and then I got stuck with it, like, what? And I have a feeling that the county board is in that same position, that, the dog catches the car, and now what do you do with it? And I with high regard for the individuals there, I think we do need to have, like you suggested, professional leadership. And I think it's a good time to build a partnership. Put a nurse or two on there, put a doctor or two on there who actually work at the place. Some knowledgeable people, maybe not you, but people like you who actually understand the thing, people actually run hospitals, and not be afraid to find efficiencies and rebuild for the future, because the future is coming and it's going to be even harder. So that's my several point idea, which I think actually could go, and I think it'd be really popular. And I think the deficit's coming anyway, but I think if there is a statewide need, it's to keep at least 31 hospitals that are at risk from being available to serve people all across the state. So that's my thought for you, and thank you, my friend. I appreciate your effort on this. Thank you, Madam Chair.
Thank you. Members, are there any other questions that you have for Ms. Malcolm? I was just wondering, amongst all of the other challenges that we're seeing in the healthcare system, there's a dynamic of some of the entities, making decisions about how they have to make their path forward, and we have to take that into consideration as we're looking at the whole system. And I'm thinking of, the impacts of different transactions that might move forward. And just wondering how you would see our analysis changing when we know that there are a couple, or at least one announced large transaction with Allina and Sutter Health, and potentially others. How do you see that being taken into consideration as we do our discussions about how to move forward? If you have any thoughts about that. Ms. Welcome.
Madam Chair, thank you. Well, it is a big development, and not a totally unexpected one. Folks have been thinking for some time that the rise of larger national entities was probably predictable, just given the arguments about economies of scale and the ability to kind of work across different regions and different markets. There certainly are some potential advantages to that, but I think a lot depends upon the sort of the policy signals that the state wants to send to the marketplace, how incentives are going to be structured, and what are the best ways that we can incentivize. I always struggle with that word, incentivize our health systems, who. To me, it's a good thing that they are pretty much all not-for-profit organizations with obligations to the public good and to the state, and having some conversations about what does that mean. How can we encourage hospitals to use their nonprofit status and their community benefit efforts, which I know they take great pride in, for the greater good. And for a new model such as what Allina and Sutter are contemplated, and presumably the Allina entity and region will still have some authority and some responsibilities to the state and the region. I would certainly imagine that and hope that to be true.
Thank you. Yeah, it just seems like it adds another level of complexity to our evaluations about how we sustain, or who do we sustain and help sustain. We know that they're all entities that are important to their communities, and so we don't want people to be negatively impacted by changes, and it makes it more challenging when we have to look out for some of these other transactional approaches that entities are bringing forward. So just another added element to the discussion. Any other questions or comments before we move to the Hennepin County Medical Center presentation? Well, I really appreciate your being here, and hopefully we will continue to have conversations and hear more going forward. So thank you very much for your time. Now I'd like to bring forward the testifiers who are here to discuss Hennepin County and continued discussion on the financial status of Hennepin County Medical Center. And I think we'll have enough chairs. We could have hopefully all of the testifiers can come to the table. And we'll get one more chair. So, thank you for being here today. We really appreciate your coming and spending more time on the details of what's going on. And I will let whoever is going to begin, if it's Ms. Wetland, are you going to begin? Please state your name for the record and you can begin.
Thank you, Madam Chair, members. I'm Jody Wentland. I am the County Administrator for Hennepin County. Thank you for having us today to provide another update to committee members on the financial status of Hennepin Healthcare and its flagship hospital, Hennepin County Medical Center. Joining me today, I have Joe Matthews, our Chief Financial Officer for Hennepin County, Charles Essler, the Vice President of Finance at Hennepin Healthcare, and Dr. Megan Walsh, President of the Medical Staff and Chief Academic Officer at Hennepin Healthcare. Hennepin Healthcare is not a private or a for-profit health system. It exists for a fundamentally different purpose serving Minnesota. What makes Hennepin Healthcare unique and special is that it is structured around need, access, and mission for Minnesotans. As Commissioner Malcolm just shared, Hennepin Healthcare has long experienced structural financial imbalance and has required county property tax revenue to support its operation. As a level 1 trauma center for both adult and pediatric patients, Hennepin Healthcare provides the highest level of care for severely injured adults and children. This represents the most complex and expensive care in Minnesota. One major driver affecting the hospital's finances is uncompensated care. Effectively, the care hospitals provide for which they are not fully reimbursed. To highlight a few of the points on this slide, I want to point out that uncompensated care is rapidly escalating, rising from $40 million in 2020 to $104 million in 2024, with growth expected to continue to rise. In 2024, 24% of the uncompensated care costs came from outside of Hennepin County. In addition, approximately 75% of patients rely on public payers, Medicaid and Medicare, which do not reimburse at the cost of care. When combined with self-pay patients, more than 80% of all patients served at Hennepin Healthcare System's lack of a viable payment source, creating a persisting operating losses for the hospital. Since the hospital has a much larger share of public payers and a similar percentage of commercial insurance, increases in uncompensated care add significant financial burden. It also means the hospital lacks the reserves of other health systems, making it especially vulnerable to budget disruptions. In addition, costs for healthcare, as you know, are rising. They're rising at an average of 5 to 8% annually, while revenue increases are only rising at approximately 2%. This financial mismatch has produced recurring annual losses for the hospital. As a public safety net hospital, Hennepin Healthcare has experienced long-standing structural financial challenges. Therefore, the impact of the end of the public health emergency, the Change Healthcare incident, and the UCare event had devastating impacts to Hennepin Healthcare's financials, requiring the county to provide a backstop for Hennepin Healthcare's payroll beginning in January of 2026. Moving to the next slide, you can see that as a public safety net hospital, Hennepin Healthcare service is 1.3 times more public pay program patients compared to safety net hospital peers across the country, and 2.4 times more than Minnesota Metro hospital peers. The high rate of Medicaid patients make the hospital especially vulnerable to changes in Medicaid policy and eligibility, as Mr. Essler will talk about shortly. In light of the financial challenges, Hennepin Healthcare has taken short-term steps such as closing programs, reducing staff, freezing wages, and freezing hiring for newly created positions. These actions provide only temporary relief while a long-term solution is sought. Property taxes alone cannot meet the system's ongoing needs. And now, I'd like to turn over to Mr. Charles Essler with Hennepin Healthcare. Thank you.
Welcome to the committee, and if you can please state your name for the record, and you can begin.
Yes, Madam Chair. My name is Charles Essler, Vice President of Finance at HCMC. And what we will be talking to you about here is continuation of Ms. Wentland's discussion on the payer mix. So here on the slide that we have ahead in front of us, the uncompensated care aspect is included in that top line that's kind of a lavender color is the people who are self-insured or uninsured. And it rose from 6% back 5 years ago to now 8%. 2025 numbers are preliminary. And it looks like a small percentage, but that is that increase of the $60 million that Ms. Wentland talked about previously, from the 40 to the 104. That is a demonstration of the vulnerability of the hospital to the payer mix. The other part to note on here is the gray box, and the Medicaid aspect is the gray plus the orange together. The gray box, as you can see, was 36% back in 2020, is now closer to the 30-29. And again, you say, well, that's a few percentage points, but those few percentage points are from, thank you to previous years, we have directed payments. Those directed payments are tied to the managed care program. So as that goes away, so does the directed payment impact. So what we've seen is a degradation and a shift in the payer mix. The tune of, that's about a $70 million loss of revenue annually to serve the same patients that we saw 5 years ago. So in the other part of that, we also have the volatility of that, as Ms. Wentland noted, was with that high of Medicaid percentage, we will be disproportionately impacted by the forthcoming, now called HR 1. The other, can we go to the next slide, please? So this answers a few of the other questions about the challenges that we have today and what we have in the future. So this slide, if you look at the bottom 2 and 3 colors, that is what we're going to call the operational costs, today's challenges. The HR1 additive challenges are the purple, the dark purple, and the very top light purple, and I'll talk about those in a minute. The overall, if you sum the yellow, the blue, and the green, those total about $187 million a year of operational challenges baseline. So that's part of the operational asked on the table today. The additional purple over the 10 years, approximates $1.7 billion in total reductions in revenue over the course of the time listed. That impacts, by DHS estimates, this data came from DHS with MHA estimates of impact, and it was 140,000 people will lose access in that purple period. To go through what each line of that color means, the bottom is the uncompensated care is the yellow. So the uncompensated care is about that $100 million that we talked about annually. So that's the base. And that has a slight inflation factor of a 2.5%. The second color that you're stacking on top is the base. That is the equipment purchases. So as you've heard or seen, there has been pent-up demand for equipment and IT, those kind of, we'll call capital purchases outside of building. That is about, that approximates 30 to 50 million a year for an entity of our size to repeat that year over year and keep the equipment, replace MRI machines and similar equipment and billing infrastructure, those kind of things. The green represents what you'll hear other hospitals talk about, but is amplified to us, is the inflationary gap. So you have inflation, when you have 75% of your public programs plus self-pay on top of that to 80%, to Ms. Wentland was saying, you have about a 2% inflation revenue that because HCMC cannot go back and negotiate with the government what the rate should be. But on the cost side, like all healthcare, you have costs that range from 3 to 5%, sometimes 8 to 10%, depending on drugs, personnel, those kind of things. So costs go up 3 to 8%, revenue goes up 2%. That gap, that inflationary gap, creates this challenge every year of solving more by trying to find efficiencies, cost opportunities, et cetera. So, and that is, in the purple does not have any inflationary adjustment on those values for the impact on top of the base. These are conservative estimates because of that, and they are estimates. The 2% green, that roughly reflects the net gap, is on about a $1.5 billion budget, where the size of the hospital is today. All right. So, to my final statement here before turning it over to Joe will be that the funding that we're seeking is to help us with the baseline opportunity that we have and how we can help create a runway, and that runway will help us strategically address through operational opportunities, whether it be efficiencies, cost, et cetera, to address additional challenges that will be coming to HCMC and the healthcare system, but uniquely proportional to us. All right, so I turn it over to Joe.
Mr. Matthews, welcome to the committee, and if you can state your name for the record and begin.
Yeah, thank you, Madam Chair. I'm Joe Matthews. I'm the Chief Financial Officer for Hennepin County. And just talk briefly about the capital structure. When we say capital, we mean the physical infrastructure of the hospital. Hennepin County has owned the HHS campus since 1964, acquired buildings over a period of years as the hospital evolved. And that campus is about 4 million square feet. It covers 8 city blocks. The county has been responsible for the investments in that property. And what you see in the slide is just the investments from 2007, when the hospital was separated from the county in its current structure through 2025's capital improvement program budget. Much of the campus is aging. Many of the buildings are 50 to 100 years old. There is one specialty clinic, which you may be familiar with if you're familiar with the campus, that was constructed around 2014, 15, and 2016 is when that building was put in place. The hospital needs approximately $25 to $30 million per year currently just to keep the funding or the buildings functional and to continue to deliver great care. There's complex mechanical, electrical, and building systems, and again, those all need replacement as they age. You can see here the trend line. There are ups and downs depending on the various needs of the facility. There was a little bit of a downturn coming out of the pandemic as priorities were really focused on that. But you'll notice at the tail end, there's a pretty rapid growth. And what you're seeing here at the last bar is the 2025 capital budget for human service projects downtown. Looking ahead, what we have for resources, these improvements are paid for by property tax dollars. As I think you're aware, we levy $38 million a year for uncompensated care that we provide to the hospital currently. But we also levy property taxes to either pay cash for some of these projects or to pay debt service on all of the projects where we issue bonds to move these forward. We can go ahead and jump to the next slide. One of the things that we've talked about with looking at new revenue for the hospital is looking ahead long-term. These old buildings are expensive to maintain. And at a certain point, as you know, it's more expensive to maintain an older building than to look at moving them into a more compact and consolidated, more efficient, modern building. What we've put out there, just to be transparent, an $80 to $160 million range to support debt service. $80 million for over a 20-year period would support about $1 billion investment. 160 million would support about a $2 billion investment. Again, the campus has significant size. We also recognize that included in this is a need for the hospital to replace large equipment. So Mr. Essler mentioned, $30 million a year for medical and IT equipment. Think about the things that you see in the rooms where you receive care. But there's also large, as you know, very large capital pieces of medical equipment that are very expensive. And at some point, those will also need to be replaced. They have long life cycles, and it's okay for us to capitalize that. The last piece, just to call out, right now, the only debt that the hospital pays is for the specialty care clinic. There's about $131 million of outstanding principal on those loans, and they do pay that debt service each year. If they were unable to make that payment, the county would have to levy property taxes to make those payments on their behalf, and that would cost property taxpayers about $12.5 million annually through the end of that life cycle of that debt.
Thank you. And now, Dr. Walsh, I don't know if you want to, if you could move closer to the microphone or switch places, whatever works.
I'm pretty loud.
Okay. And welcome to the committee. If you could state your name for the record and begin.
Madam Chair, members of the committee, my name is Dr. Megan Walsh. I'm the Chief Academic Officer and President of the medical staff at Hennepin Healthcare. I'm here to speak about how our ability to train our future healthcare workforce is also at risk. As an academic medical center, we pair clinical care with research to train the next generations of physicians, advanced practice providers, nurses, pharmacists, lab and radiology techs, paramedics, and many more. This role is especially critical as Minnesota faces a rural healthcare workforce shortage. I went to medical school at the University of Wisconsin-Madison, but I chose to train at Hennepin County Medical Center. And like more than 85% of the faculty who practice at Hennepin, I made a deliberate choice to stay. People stay at Hennepin because of the mission to care for anyone at any time and to teach in that environment. But we are now in a period of real instability. Like many health systems, we face significant financial pressure, but as a safety net, our margin for error is razor thin. We have already begun to lose people. Nearly 5% of our medical staff have resigned since January. To maintain Level 1 Trauma Center accreditation, we must provide immediate access to highly specialized services, neurosurgery, ophthalmology, interventional radiology, burn care, and more. These are not interchangeable roles. These are highly trained clinicians. Recruitment in these areas is difficult and can take years. Retention is everything. If we lose even one or two essential physicians or APPs, advanced providers, we are not simply short-staffed. We risk our ability to maintain our Level 1 trauma accreditation. That designation isn't symbolic. It ensures that when the most critically injured patient, whether from Minneapolis or rural Minnesota, needs care, there is a place that is ready. But recruitment's also at risk. Imagine you're a young neurosurgeon who's building your career. After 15 years of education, 4 years of college, 4 years of medical school, 7 years of residency, you want to practice in a place that has long-term stability. Will you choose a job if you think your employer isn't going to exist, even if you love the mission and the work? We train physicians from across the country. Residency and fellowship positions are contractually binding. When trainees match to a program, they commit for 3 to 8 years. More often than not, they stay where they trained. If there is uncertainty about our stability, applicants will choose other programs. That impact is not immediate, it's delayed and prolonged. A single-week recruitment cycle can affect our workforce pipeline for nearly a decade. But sustainable funding can support us. It can support us through the ability to retain our specialized workforce required for high acuity care in our Level 1 status. It can create the ability to maintain our training programs, which depend on experienced faculty, physicians, and strong applicants. And critically, the runway to design a more sustainable future. Without a runway, we are forced into a cycle of reactive decisions, closing services, shrinking capacity, losing talent, each step making recovery harder. The impact of that instability does not stay within our walls. It is felt throughout the state. Hennepin Healthcare is a statewide resource. We're a level 1 trauma center for adults and children. We're a major training site for Minnesota's physician workforce. We are a safety net provider for some of the most complex and vulnerable patients. Thank you for listening. This is the time to act, because delay will cost us the stability, workforce, and care our communities depend on.
Thank you very much. Before we go to questions, I would like to probe a little bit further on, in terms of financial impacts of changes going on. There was, back to the paramix trend slide, and then the following slide, I wondered if you could talk a little bit more about the kind of the compounded impact of two things going on. One, you mentioned that the managed care, the Medicaid managed care proportion is decreasing, and that's an impact, due to some Medicaid enrollees not continuing on after the public health emergency. But that also, it's a trend that population is going down, and that will be affected by HR 1 as well. But then there's also the impact that decrease has on the directed payment amount that you receive. And if you could talk a little bit more about that and the following slide with the purple, and how that bar is increasing over the 10 years going forward, and why is that bar increasing? If you could just explain that a little bit more, I'd appreciate it. I'm not sure if that's Ms. Wentland?
Madam Chair, members, I would ask Charles Esser, and he'll be able to walk through.
Mr. Essler.
Sure. Madam Chair, yes, you are correct in that the end, what you're seeing is the end of the public health emergency, to your first point about the declining shift and how it's impacted who is eligible for a program and the continued churn now. How that leads into that second slide of the purple, there are two aspects of that purple which I'd forgotten to mention. One of them is the light purple, and that is the eligibility churn. So the workforce impacts, and those are the estimates of the churn of the workforce. I believe that was the OBA's largest savings cited. The second part is the dark purple. The dark purple is our actual directed payments. And the directed payments going away every year, but it's not, it grows over time. It doesn't take effect in year one and have the same effect every year. It actually is 10% per year for 10 years till it goes away. And that starts in 2028, which is why the purple, actually the dark purple starts after 2027, which is the eligibility churn. I don't know if that helps.
Thank you. And when we hear about projections of eligibility churn, it is related to factors within HR 1, and as you mentioned, the largest impact having to do with the work requirements. And so just members, we've had discussions about that. This is a way to help quantify what the financial impact is going to be of that churn and people not being able to retain coverage through the medical assistance program. So thank you for that. And then one other question. I know that earlier Senator Coran was talking about governance. I wondered if you could speak, Ms. Wentland, to what you've started doing last December related to a specific effort that the Hennepin County Board of Commissioners requested that you take on, and then kind of what the status is of that work to create governance recommendations. Ms. Wentland.
Madam Chair, members, thank you. The Hennepin County Board has been very clear at the onset that their role in stepping in as the temporary Hennepin Healthcare Systems Board is a temporary position, wanting to look at long-term structure that is going to support Hennepin Healthcare Systems in the moving forward and supporting the financial health On December 11th, a board action was taken by the county board directing me as the county administrator with staff to address a variety of issues and to bring back to them information and data and recommendations around long-term permanent governance for the hospital. Areas of priority for them was how to assure transparency, how to assure engagement with community, patients, providers, workforce in the healthcare system. A work plan, a mid-report was due in March that was provided to the County Board of Commissioners. That work plan identified 3 aspects of the work. Number 1 is to review the current statute in place and identifying where are the opportunities in statutes for the statute to be strengthened or maximized to assure that there is a strong board meeting the needs for the hospital, bringing in expert support for the hospital around finances, healthcare, workforce needs. Secondly, to evaluate other public safety net healthcare systems across the country. In particular, healthcare systems that have forms of some form of local revenue, local tax dollars supporting them, and looking at their governance structures and better understanding how that is similar or differing and where are those opportunities of learnings for us as we look at what that future governance is. And third, interviews with current and prior stakeholders, including prior board members, county board members, HH board members, and other leaders and critical stakeholders can help guide their experiences and what they think went well and what they felt could be improved to strengthen the role of the HHS board and their capability to lead and their relationship with county board in that process. We have a briefing scheduled for our County Board of Commissioners next Wednesday to provide them an update on this work, and our goal is to provide them with the information and the direction that they need to move quickly in governance decision, and the goal is by the end of this year to actually begin implementing, latest at the end of this year, begin implementing that new governance model for the hospital.
Thank you for providing that. Members, do you have questions? Senator Udke.
Thank you, Madam Chair. And I'm going to start back on one of the slides that you just were talking about, the one where it's the Hennepin Healthcare System's operating impact, and you've got the various colors. The top color being the light purple for Medicaid disenrollment. That block stays the same from 27 through 38. What kind of numbers of people are you calculating into that block of color there?
Mr. Essler?
Madam Chair, Senator, it would be, I don't remember the HCMC specific number off of that. The state number was 140,000, and we proportionately applied HCMCs to that number when we did the analysis. So whatever that would be, I don't have the specific counts of people. But the reason also that it is holding steady is because we did not include inflationary factors or other complexities that could cause that number to go up or down. So it was what we held today based upon the DHS and MHA estimates, and that's what we have there, if that answers the
Senator
question.
Udke.
Thank you, Madam Chair. And that's what I was kind of looking for, because I had heard the number 140,000 earlier, and we know that's a statewide estimate. But you've taken your portion of the patients you serve and calculated back. So that's good. I was hoping we weren't using 140,000 on these calculations. Next question is because you've got quite a large number there when I look at the uncompensated care numbers, and it looks like it's growing 35, 40 million over this projection. If someone comes in that doesn't have any coverage, you've provided care now, but what steps does HCMC take for payment on these that come in without coverage? I mean, must have some steps that you do to try to pursue collecting for the care that you provided.
Mr. Essler?
Madam Chair, Senator, you are correct. So every patient that comes in has to register. So they register when they come in for whatever care they are attempting to receive. And when they register, if they identify that Obviously, you've trended. If they have a card, we capture the card if it's a local commercial or whatever it might be. If they do not have insurance, what we have is a registration office, and it's financial counselors. So financial counselors will work with the patient, and their idea is they try to work to get through the information that they would need to provide on their overall income levels, get them insurance, get them on a public program, what are they eligible for. The first and foremost is trying to get them on a public program, typically Medicaid or something along those lines if they're eligible. If they're not eligible, or say they fall under the, we use a 300% federal poverty limit is our threshold. If they fall under that threshold, they would be eligible for charity care if they don't qualify for a public program, or for those people who, admittedly, there's people on high deductible plans. There's, and they might have coming in for a variety of reasons. And when they come in, they cannot pay for maybe some of the costs that they had. Again, if they qualify because they're under that federal poverty limit, they would still be considered charity eligible if they have a high deductible plan but low income levels or assets. The other part is, of course, bad debt. So the uncompensated care is two pieces. Number one is charity care, those who can't pay. And number two is bad debt, those who can pay but don't. So that's the two aspects. Bad debt is a much smaller portion of that number. The vast majority is charity at our facility.
Senator Edke?
Thank you, Madam Chair. And just one little follow-up to that, because you kind of explained the ideal case where you'd have a chance to work with them prior to receiving care, but I'm sure you've got all those that come in that are really sick or come in through the emergency side of things. So you're always kind of chasing the tail, as so to speak, trying to meet with them during care or after care, but I understand your challenges, so thank you.
Other member questions or comments? Senator Abler.
Oh, thanks, Madam Chair. This is a good hearing and an important one. And I already had my comments from before about a suggestion. Just I do have a question and a comment. And so this directed payments thing, I actually have two questions. How much do you get now on directed payments?
Mr. Essler? Is that?
Madam Chair, Senator, it ranges by year depending on utilization and population, but it's roughly the 100 to 150 million a year. We have had close estimates of over 150 a year. So it is material to us.
Right.
Senator Abler.
And Madam Chair, and those are all going away eventually? Is that what this shows?
Mr. Essler.
Kind of phased in.
That's correct. Under the current legislation, yes, it would be gone in 11 years or 12 years.
Okay, that's helpful.
Senator Abler.
And I'm all about solutions, and thank you. I mean, the preamble of everybody's speech is, hey, we're really doing a good job, you need us here, and everybody's like, oh, yeah. And so there's 4 weeks and 5 days left of the session to pass. We can't pass a law on Monday, the last day. So time is getting kind of short, and Keith Ellison, my former colleague, wrote an op-ed today. Great place, pass the sales tax. I just want to give you a thought that I think the sales tax is not going to pass. And so do you as a crew here have an alternate plan that you're going to bring forward to try something to make you work? And if you're not, I allow you to take the Fifth Amendment if you want. But an impossible solution is not a solution. So if you want to comment about that, I'm happy to hear your comment.
Ms. Wentland, you can feel free to comment. I will say, Senator Abler, we had hoped to have the proposal that I've been working on with my team ready to post today, the draft language, and we will be doing that today, but we didn't have it ready in time to post before the hearing, and then we will have a discussion about it tomorrow. And that does include a specific proposal to provide a grant to Hennepin County. So along with other hospitals and other.
I think just one thing else.
Senator Abler.
I'm going to miss Senator Mann being here. It's ironic that the reason that this is failing, Madam Chair, is the effort of the government to fail to keep pace with the costs. So just ironic, that's all. So thank you. I'm going to miss you. Senator Mann.
Ms. Wetland, did you want to comment in general about funding strategies and your preferences? I don't mean to take away anything from what you want to express. I just wanted to make sure people knew that we are coming forward with specific language soon.
Madam Chair, members, first of all, thank you for the opportunity to present. And we're here to partner. We stand here to support. What are those options? They are complex. This is challenging. As you can see from the financials, they are significant. And we can't do this alone. And that's why we are here. And we will work with you on what is the best path to support Hennepin healthcare systems. And as Commissioner Malcolm said, we have a longer issue to look at our healthcare system in general, and we want to be at the table to support that work.
Senator Curran.
Thank you, Madam Chair. And with your previous comment, maybe it's better for tomorrow when we actually look at a bill about Hennepin healthcare. But just, I've met with a variety of the organization, and we're going to have to do a much better job to sell to the rest of Minnesota why you matter. We know you matter. And the other piece, the governing, I like so far, we're still a long ways away from having a governing board. Greatest concern, how are you going to root out political ideology, which I think has infested creating many of your current problems. But we're interested, I think, when we come back, maybe just a precursor for when you come back and talk about those, what are those obstacles that you see today, right? How are we in your way? Funding, we got it. We see this, we got the charts. What are those operational things that we are somehow have impeded your ability to operate creatively across all segments? You got 6 identified segments from Medicaid, right, and compensation, all of them. We do a lot of things on commercial payers. We do a lot of things on Medicare payers about incentives and disincentives, right? How to bend the curve. What are those? How do we bend the curve across every one of those segments? And are there obstacles? I think, I spent 3 hours, I think, in your addiction clinic last week. I think there's really good things happening, but you're going to have to talk about them more. So, and we'll help. Your staff knows I'm committed to helping. And also, I think in the Hennepin County Board, when Commissioner Lundy was in my office, they're trying to bend, or at least the information he gave, for trying to redirect 40% of 911 calls, right, the most expensive care we have, to make sure the right resources are out there, not to prohibit care, but to get that care taken through the proper network and at the most efficient cost. And so I think just tidbits about what is it that are meaningful that no one will know. We're going to need to hear those things so everybody can understand, why does it matter to me? The addiction clinic, right, serving all of Minnesota, the not only the training for your Trauma One, but the training that you provide on a continuous basis and real-time support for all of our rural hospitals, right, in that continuum of care or saving them and preparing them for transport or whatever it is. Those are the things we're going to need to hear more. But also then, how are we in your way? We got the funding piece, and what else is it that we need to do to be creative so we can be comfortable moving forward with a large funding short-term patch, but something that's significantly and material will matter in the future. So thank you. Thank you, Madam Chair, as well.
Ms. Wetland, did you have any comments? Okay. I think that gives you some food for thought and ways that we can assist you in getting information out to our committee or to others. Please let me know. Senator Mann.
Thank you, Madam Chair. Thank you, everyone, for being here today to go over what's happening. But it looks like, from what you're saying, that because of the Medicaid disenrollment, which occurred because of H.R. 1, and because of the decrease in directed payments, which is the health care paid for by the federal government to the most vulnerable people in our state, because of the decrease in those payments, also caused by H.R. 1, those appear to be the 2 biggest drivers leading to the financial struggles that you are describing today.
Ms. Wetland?
Madam Chair, Senator, so they are drivers, but I actually would like to go back to the other slide as well, because one of the issues as the county board leaned in because the hospital is in crisis. So prior to HR 1 has begun implementing, the hospital has already experienced financial crisis. So I just want to highlight a couple things, what this has already occurred. So there is what's already happened, and there is what is going to happen. What has already happened, so as Mr. Essler indicated on that light lilac slide on top, this uncompensated care portion, going from 6% to 8% was a change of $40 million of uncompensated to $104 million. So that was one piece that just happened that the hospital has had to determine how to absorb, a $60 million increase. In addition, the middle gray, the managed care, the churn in Medicaid. So for the hospital to actually receive the directed pay rate, which is a better rate, thank you, that has helped the hospital. That rate though, if a patient comes in and is on Medicaid, but it's the orange Medicaid, the fee-for-service Medicaid, the rate is substantially different. The fee-for-service is substantially lower. And as you can see, that percentage has slightly gone down. So in regards to current patient population and payer mix, that light gray going down to the 29% was the 70 million. So the hospital's experienced just in those two pieces, two factors of the 60 million plus increase in uncompensated and the 70 million loss in directed pay rate because of the lower Medicaid rate. Those are two factors on top of, as Mr. Essler said, the rising cost of healthcare at the same point that it's only a 2% increase. That's current in the gap. That's around 150 to 180 million. And then the next slide that shows the light purple and the dark purple, that's what's coming. That's going to be on top of what the hospital is currently experiencing in financial shortfalls.
Senator Mann?
Thank you, Madam Chair. This is something we have seen across the board, across all hospitals. Certainly after COVID, we never quite recovered. And we have data saying that perhaps we are worse off now than we were even before. But is it accurate to say that we have this baseline where we have systemic failures in our healthcare system because of the way it's structured? And on top of that, we now have HR 1 coming in and almost dismantling the inefficient and inadequate system that we do have in place.
Ms. Wentland?
Madam Chair, Senator, yes, so as you look at that, current system is already in crisis. As we look at a revenue source to help stabilize the hospital, it is only giving the hospital the runway that is needed, and not just Hennepin Healthcare, but our healthcare system across Minnesota, to determine what needs to occur to manage the headwind that is coming with HR 1. As you can see, by 2038, those are enormous numbers.
Senator Mann?
Thank you, Madam Chair. So, I mean, we're having this conversation here today of how to keep HCMC open because A, we have a crumbling health care system infrastructure to begin with. And then on top of that, the federal government has come on and cut funding. And now we're here having this conversation because the state has to pick up the pieces to make sure that one of the most important healthcare facilities in our state doesn't close, where we have burn units and ECMO, and we train half of our healthcare workforce. Since the federal government passed HR 1, we have been having multiple committee hearings and sounding the alarm about the destruction that is coming because of that bill, not only to Minnesota, but to the entire country. And I hope that our colleagues are finally listening. We aren't here because the federal government hasn't kept up with cost and funding. We are here because they are cutting off our funding. So thank you, Madam Chair.
Thank you, Senator Mann. Any other questions? I see we're over time a little bit, but if there are any other questions, I'm not seeing any. I do really appreciate all your attention and willingness to come and talk with us today. If we have more questions coming from the committee, we will certainly let you know and provide provide those questions to you. But again, thank you so much for the slides and the detailed explanation of kind of where things are at. So thank you, and I will, as I mentioned, we will try to get our proposal posted as soon as possible, and tomorrow we will have a walkthrough of our budget, and we have reached the end of our committee, and we are adjourned.